Imagine you're walking across the road, you trip, you sprain your ankle, and it's a quiet country lane. There's no cars, there's no traffic. I show patients this image of that ankle. How much does this hurt now? And patients will usually say 9, 10, 11, on the VAS score. This is really painful. How much would it hurt if you did exactly the same injury, but this time there's a big London bus coming straight for you? How much would that hurt now? Of course it wouldn't hurt. And patients often say, yeah, no, it wouldn't hurt. That's weird, isn't it? I always say to them, what is that about? A great question to ask patients. What's that about? Why would the ankle not hurt when the big red bus is coming for you? How do you explain that? Some patients do the very simple CHO thing again, and they say that's just adrenaline. But saying it's just adrenaline is a bit like saying I can make a really complex cake with one egg. One egg can make a really complex chocolate gatto. It can't. It's just one ingredient in a very, very complex mix. So when patients say to me, yes, it wouldn't hurt if the bus is coming straight for me, which part of your body is making that decision? Is it your ankle or is it your brain? Of course it's your brain. Of course it's you're subconsciously getting out the way. You're immediately saying this bus is going to hurt more than this sprained ankle. So this is where we can start to link pain perception and hearing perception together, that pain does not come from the ankle. We have nociceptors, a bit like in the ears, you'll have just sound wave receptors, but these are not hearing receptors. All we're doing is picking up on data, on information. And in the same way, we have nociceptors. Nociceptors, Patrick Wall once said that nociception, we made a simple trivialization back in the 1970s. We thought of nociceptors as pain fibers, but they're not. It's just data, just information, just warning data. Nociception is a subconscious encoding of noxious stimuli. Pain is a far more complex, conscious experience, which is based in context and threat. One thing we do know is that if we can help people make sense of this, if we can help them understand how pain works and why it does what it does and the fact that it's linked to threat, you can, as we've already talked about, you can have a therapeutic result. Therapeutic neuroscience education. You can reduce stress and anxiety and worry and concern, and you can provide people with reassurance to enable them to take the brakes off their life again, to get back to doing things that they enjoy. So pain education can be really helpful, but maybe we need to develop our skills as teachers.